Hello everyone, my name is Ryan Sherry. I'm a second year medical student at OSU and will be presenting my group's project, which is titled Race and Dermatology Clinical Guidelines, a systematic review of impacts on health equity. Before I begin, we'd like to say thank you to everyone who is taking the time out of their day to listen and learn about our study. Clinical practice guidelines are evidence-based recommendations designed to inform healthcare decisions and improve patient outcomes. However, race, a sociopolitical construct, is often misused in medical contexts, including dermatology, which relies heavily on visual diagnoses. Misuse of race can reinforce structural inequities. And this study evaluates use of race in dermatology clinical practice guidelines to identify opportunities for promoting health, equity, and ensuring inclusivity in dermatologic care. Our objectives were that this study should aim at reviewing dermatology clinical practice guidelines from January 2019 to April 2024, and to assess how race influences health equity. We analyze race references within the guidelines to determine whether they perpetuate or reduce disparities in care. Our goal is to identify areas where guidelines can be refined to foster equity and inclusivity in dermatology practice. Our methods is that we ran a systematic review and examined 19 dermatology clinical guidelines published between 2019 and 2024. Our inclusion criteria were guidelines referencing race or ethnicity and being relevant to the field of dermatology, and guidelines with recommendations for patients 18 and over. And for our review process, we had 2 independent reviewers that classified race mentions in 3 distinct categories, one of them being positive, which was addressing disparities or fostering inclusivity, another one being negative, which was perpetuating stereotypes or biological essentialism, and neutral, ambiguous or undefined context when used about race. Mentions were also categorized by context, which was background, epidemiology, clinical recommendations, and future directions. For our results, we identified 33 mentions of race in the 19 guidelines, 39% in background epidemiology, 33% in clinical recommendations, and 27% in future directions. The majority of mentions, 88%, were positive, highlighting equity and inclusivity within the guideline, and only 9% were negative, reflecting stereotypes or biological essentialism, and 3% were neutral, indicating the ambiguity. These results suggest that while race is primarily used in a constructive manner in dermatology guidelines, there is still room for improvement. And attaches our Prisma flow diagram outlining the process of study selection for this systematic review, initially with our 159 articles, which were returned through our search. After screening the titles and abstracts, 132 articles were excluded for various reasons, including duplicates, incorrect populations, or being the wrong article type. This left us with 27 articles for full context screening, and after further assessment, all 27 articles were retained for data extraction. Finally, data sharing information was successfully extracted from the 19 of these 27 articles. And for our conclusion, the findings of this study highlight that race references in dermatology clinical guidelines are predominantly positive, with a strong focus on equity and inclusivity. However, a small percentage of negative and neutral mentions indicate areas where the use of race could be better framed to avoid reinforcing stereotypes or certain types of biases. And to ensure that race is used constructively to advance health equity, we recommend incorporating frameworks such as cultural humility, which encourage continuous self-reflection and understanding of diverse patient populations. This approach will help guide dermatology practitioners in making decisions that promote more equitable healthcare outcomes for all patients, regardless of their racial background. Thank you for listening to us and learning about our study.